Okay, Al, if you're ready, we'll get started. And
Okay.
welcome everybody who is logging in. My name's Jamie Edwards. I'm director of the Prevention Training and Technical Assistance Center here in North Carolina. We provide training and TA services to substance abuse prevention professionals statewide. And one of our missions is also to support certification efforts throughout the state. And this particular topic in terms of HIV, AIDS, STDs, and so forth is one of those annual trainings we tend to offer via webinar for individuals initially in the prevention system, but we're beginning to open it up to others as well. We have Al Bishop with us today. Al is the Corporate Compliance Officer for Roberson Healthcare down in Roberson County. And Al, he's one of our long-term partners and our HIV STDs expert of sorts. It's in-house. We use contractually. And I'll let Al introduce himself in a few minutes. This is the first day of a two-day webinar. We begin today at 9 a.m. and finish up about 10:30. And we will also begin tomorrow at 9 a.m. and finish up at 10:30. We have a large number of individuals who have signed up today. It's over 180. And so far, we have 88 people who have logged in. So I expect that to increase. Therefore, the system will automatically mute everyone upon entering the GoToWebinar interface. If you have questions or want to throw out items, please use the Q&A box, the question box, and we'll be happy to track those for Al. And in addition, under handouts are all the handouts that can be downloadable or is downloadable for today and tomorrow. You can download those at your leisure as well. We will ask everybody to complete a training evaluation form, not today, but tomorrow. At the end of tomorrow's session, 60 minutes afterwards, you will receive a training survey. So we ask everybody to fill that out as soon as they can. Plus, we will need a couple of days to confirm rosters and sign-ins and participation as well. And you will be receiving a certificate of attendance within 5 days via email from an email address, Alexandra Elms, ELMES. If you don't receive that within 5 days, you can just let us know, and we'll make sure that you receive your certificate via email. So last but not least, Al, I think I'll turn it over to you, and you can get us started.
Wonderful. Thank you, Jamie. Good morning, everyone. Even though I can't hear you, it's good to have you on board this morning. I'm hoping to have a wonderful time today and tomorrow. I understand that this can be kind of not exciting information, but hopefully we can make it interesting enough that we can stay tuned, and hopefully we can make this where we can help other people. So as we start off, some may have seen this presentation before. Not a lot of difference in there. A lot of the statistics have changed maybe a little bit, but I just want to make sure it's a refresher course, if nothing else. And it is the basic HIV/AIDS 101. However, if you have questions throughout the presentation, as Jamie stated, that please put those in the chat box. We want to know what those questions are. And if I don't answer them before the presentation's over today, maybe we can get those answers and get them answered for you tomorrow. But at the very least, I want to be as participatory as possible and to make sure that we can stay abreast of what's going on in the world of HIV and AIDS and how we, as prevention professionals and maybe behavioral health specialists, can be beneficial to those that may be infected with, living with HIV or the condition AIDS, and how we can help them to maybe have a healthier, happier life. So as we start off, let's just look at a couple slides here about what HIV and AIDS really is, and then what we can do to make it better for others by our knowledge. All right, as we go forward, let's move forward. All right, so, when we first start off talking about HIV and AIDS, we want to ask the question, what is HIV? And is there a difference between HIV and AIDS? And for some reason it wants to jump back. All right, we'll try it again. All right, so HIV, it's the virus that causes or can cause the condition AIDS. And the reason why I say can cause is if HIV is caught early, like breast cancer and other infections or conditions, if we get it early, we can do a whole lot more with it. When I say we, we're talking about treatment professionals and, of course, the patient that is living with this condition at the time. So it's important to know that if we can get this information about this early on and get people tested early, we have a lot better options for people, and they do not have to get into the AIDS condition, or we can definitely delay the onset of AIDS condition for many, many, many years if we work on this. So HIV is the human immunodeficiency virus. It is the virus, when it enters the human body, it does attack the immune system and makes it weak. What it does is it enters the helper T cells. Sometimes we call them part of the white blood cells. And the helper T cells are actually the ones that go out and kind of look for infections and diseases and conditions that are not supposed to be in. So, this is not what's supposed to be here. Let's go ask for reinforcements to come in and kill these bugs that are in here, as it were. And so it attacks our early warning system is what it does. And what it does is it rewrites the cell's DNA and reproduces those in large numbers, as the screen states. It's kind of like a virus getting into your computer, one that you didn't know that was even in there, and it takes control, takes over, and then it shuts your computer down. I don't know if anybody, I can't see anybody raising hands, but if you were to raise your hands, how many of you have ever had the fright of someone taking control of your computer over? That's a pretty scary thought, to think that they can get in there and get all your information and take over your computer, and it makes it where it's not even usable anymore, and actually can shut it down where it can no longer work. Well, this happens a lot, very, very similar in our body. And when the cell, what it happens is it uses your own DNA and rewrites it. It reprograms your own DNA. Instead of making another one of you, it makes another one of you plus HIV, and it just multiplies rapidly. So this is a very crafty, thrifty, and hardy virus once it gets inside the body. Now, outside the body, it's very fragile and it can die very easily. But once it gets inside the body, that's where it starts doing the damage. And of course, like I said, because it's HIV body smart, look at this part. When actually it makes more of itself, it actually causes that cell to die. When the cell dies, it wraps itself in the debris, and it makes it look like just part of your body that's a dead skin cell. And then, of course, it bumps into the next helper T cell and enters it, and then begins the process all over again. It's a pretty smart system, So HIV, what does it stand for? H, because it's human, because the virus that we're talking about only infects human beings. And I, because it's immunodeficiency, it causes your immune system to no longer work the way it used to work. And it works less than what you would like it to work. It works poorly, for lack of a better word. And when it doesn't work really well, you don't go very far. So let's kind of look at this like a car. If we look at a car and we cut off the air intake, we cut off the fuel, the car's not going to go anywhere. You can have the best motor, you can have the best engine, you can have the best wheels and tires, it looks beautiful, but if we don't have the right fuel, we don't have the right combination of air and fuel mixture and fire, it's not going anywhere. So if we cut off those supplies, then your car is inefficient. It's pretty, it's nice to look at, but it doesn't really do a whole lot for you. Or you have one, maybe we have one with a great, wonderful motor, and then you went to go to put it in gear, and somebody says, "Oops, I forgot to put the transmission in there." You're not going anywhere. It's not, unless you're, like the Flintstones, and you just, put your feet on the floor and then start pedaling hard as you can. It's not going to go very far, right? So when we when it makes our immune system deficient, it no longer works the way we'd like it to work. It works not properly or doesn't work at all, and then any of those bugs and viruses that our body is naturally fighting off can no longer be fought off. So I don't know how many out there has a pretty healthy immune system. I hope most of you do. But if you have a very healthy immune system, you're fighting off millions and millions of germs, bugs, viruses, bacteria every single moment, every single day. Every time you breathe in, you're breathing in germs. Every time you're touching something, you're touching germs. They're all around us. They surround us every single day. And our immune system naturally fights those off. So what happens when the immune system no longer works properly, guess what? This is what happens. Those bugs and viruses and infections that are out there that our body is fighting off can no longer fight those off. So that's what happens, and our system is subject to those viruses and bugs because our immune system cannot fight it off. And V, because it's a virus, because the organism is a virus, which means it's one of the characteristics that it makes it incapable of reproducing by itself. More or less, it's a parasite. It's like a tick. It's like a flea. It's like any of those that require a human body or another host for it to live or survive. That is interesting to know. But a virus is very crafty. It's very small. Some are so small it can slip through the cracks of a porcelain plate, someone once told me. I said, that's pretty interesting. I don't want any of those at the end of my plate at all, but it's nice to know that they're very small. It's hard to see those, and it takes a really good team of individuals to be able to help us, and we call those doctors. We call those medical professionals that can help us to eradicate these. And there's we'll put a plug in here for UNC Chapel Hill, go Heels. UNC Hospitals is a big research development there for HIV and AIDS right here in our own state. And of course they partner with other types of entities around the world and to making strides in HIV and AIDS work. So HIV, that's what it stands for. And AIDS. Now, this is the difference. So if you're looking at your test and you're looking at your quiz to figure out what should I learn from this, there is a difference between HIV and AIDS. HIV is the virus that can cause the condition called AIDS, and AIDS is a condition that your body gets in when it can no longer fight off certain infections or diseases. So it is the acquired immune deficiency syndrome, and this condition is caused by the damage done by HIV to the human body. And when the body's immune system reaches a level where it can no longer fight off certain diseases or infections, that's when a person gets in the AIDS condition. The Center for Disease Control in Atlanta determines that a person has reached the condition when their CD4 cell count, which is also called the helper T cell count. So if you're confused already, wait. Everything that with HIV and AIDS world has at least multiple names. Like the medications have 3 different names. So if you try to learn one medication and somebody calls it something else, don't be surprised because it has different names. But the CD4 is also part of your white blood cell system, which is your helper T cells. But when that CD4 cell count drops below 200, then is when a person is typically considered to be in the AIDS condition. Usually that's when a person contracts PCP pneumonia, and they're at risk for that, and their body it makes it really difficult for their body to fight off because their immune system is so weak. And at that point, the primary desire for a practitioner is to get a person's immune system at least stable enough to be able to help fight off its the different infections and diseases that your body is fighting so hard. And at that point, a practitioner will be giving you at least one antibiotic to help you boost your immune system and to fight off these infections. And so what does AIDS stand for? Well, the word AIDS has AIDS, acquired, because it's a condition one must acquire to get infected with something. It's not transmitted through the genes, at least not as far as we know right now. And over the 36 or 37 plus years that we have had HIV in the United States, we found that it has to get inside the human body, and it's usually through some sort of entry point, a portal, and we'll talk about the different types of entries later. But one good way is through the exchanging of blood or bodily fluids. If we exchange blood or bodily fluids, then that's typically, they get that blood or bodily fluid from one person to another, then that is at risk for someone contracting some type of blood-borne pathogen. But again, that person has to have it that the blood came from. before it can be passed on to someone else. It just doesn't magically appear. Immune system, because acquired immune, because it affects the body's immune system, the part of the body which usually works, again, to fight off germs such as bacteria, viruses, and other pathogens or infections that can be carried in through the blood or other bodily fluids. Deficiency, again, because it makes the immune system deficient, makes it not work properly. I go back and tell people, which probably tells my age a little bit, is when we were growing up, our teachers used to send us home deficiency reports. It wasn't the report that we get, the grade report that we get every quarter or whatever. It was actually a deficiency report saying if your son or your daughter doesn't do well, start doing better, they're going to have a bad grade report if they don't do better. And so the teacher would send those home, and then the parents would get on to you and say, look, you need to do better, Johnny, you need to do better, Susie, Sally, and if you don't, then you're going to fail your grade or whatever. And of course, depending on the household, it might even be worse. You get privileges taken away from you and things of that nature. So we don't want to be deficient. We want to be up to par on these things. And the practitioners that we work with across the United States and around the world, our job is to find those deficiencies and help those individuals get back to a better state of health. And the last thing is syndrome. Because someone with the AIDS may experience a wide range of different diseases and opportunistic infections, all at the same time. Because you have this infection in your system, it is affecting multiple systems simultaneously, and that in itself is a syndrome. It's a collection of activities that are happening all at the same time and causing problems throughout the system. One of the things that's happened in the last 5 or 6 years that we're finding, because we have a system-wide infection, we're finding that anytime you have an infection, usually there's inflammation involved. If you cut your finger, your white blood cells go to act to defend the body and go to that place where it's injured. And there's swelling there. There's inflammation there. If you have problems with your joints, you sprain your ankle or whatever, that part gets inflamed. It gets enlarged, as it were. But what we're finding with people who have HIV and long-term HIV, even if they're not in the AIDS condition, because your body is suffering or fighting off this disease constantly with medications and treatment, your body is having inflammation, and sometimes that is widespread and makes everything even worse. So that's another thing that we're finding out with those that have HIV, are living with this condition, that we're finding that more and more people are having widespread inflammation, causing other problems than just fighting off the infection. So it's compounding itself as we're learning more about this infection and disease. So the syndromes kind of stack on top of each other and makes it even more complex. That's another reason why this is a very complicated condition that where we're trying to find new strides in finding it. Another thing that happens, and we found this out a few years back as well, is that we're finding that the virus may shut down and go dormant in certain areas, like part of the virus is active and other part of the virus decides it wants to go to sleep. And so you have medication that's out there, and it causes the virus not to be able to reproduce, but only those viruses that are not asleep. Interesting. So we get the ones that are not asleep, we get them to not replicate, and later on, we don't know how long, those that have been dormant or asleep inside the body all of a sudden wake up, and the medicine that you were taking didn't affect it at all. So they found out at Chapel Hill is that there's some cancer-related medications that helps to wake these dormant ones up so the medication can actually work with it. So I thought that was a really interesting fact that I found quite a few years back, and would like to share that with you. Thank you. I know it's a few minutes. Do we have any questions at this point? Jamie, do you think, just to see if anybody has any so far?
Yeah, nothing's come through so far, Al.
All right, we'll keep on then. All right, sounds good. Thank you, Jamie. All right, so as we're moving forward, and we've got the basic definitions of what HIV and AIDS stands for, and then we can go into other terminology in just a few moments. But yeah, let's just go ahead and go with the terminology, and then we'll go into some history. So other terminology, we talked a little bit about CD4, and we talked about helper T cells. They're the same. They're exchangeable. Healthy people can have between 500 and 1,500, or maybe even more. And it doesn't mean the more you have, the better, to a point. But I will tell you, this is an indirect measure. This is one of the early measures we as healthcare professionals would measure your CD4 count to see how strong you were and how strong your immune system was. And if your CD4 started dropping, we knew that HIV was doing something terrible in your body, and we had to do some more work. It wasn't until a while later that they realized that we could actually count the number of viruses in the body and the number of HIV that's in the body in a sample of blood to get a better understanding of how HIV was prevalent and what kind of damage it could be doing inside the body. So it found out and made a term that come up called the viral load, or load of virus in a sample of blood. And so what it is a direct measure, and the amount of HIV present in a sample of blood, and that gave us a much better indication of how much virus is there, what kind of damage it's doing to the body. And I bring these up for a reason. If we don't know that you have that an individual has HIV or has contracted HIV, then we definitely can't do anything about it. The second thing is that if we don't know how much is in there, then we don't know what kind of damage is being done to the body, and what we can do to stop that, reverse it, or at least put it on a pause so we can get better healthcare results for that individual. And the third thing is, what stage are you at? Where are we at with the combination of your CD4 and your viral load? Because if we can keep your CD4 up and your viral load down, that'll put you in the best state of health until we can figure out a way to eradicate HIV completely. At this point, there's only been a few cases where HIV has been, I don't want to use the word cured, but essentially there's one named Tim Brown. He had an unusual bone marrow transplant. He had HIV, and then he's the only one that I know of. I think he was in England maybe, and he had the bone marrow transplant, which is a very risky procedure, and he happened to get bone marrow that was resistant to HIV, and essentially he was cured, but we can't call it a cure at this point because it's been difficult to duplicate. There's been 2 or 3 other incidences where they've had bone marrow transplants, but they were not as successful as this one individual. It is a very risky procedure, and it's not something that they can do, but it is definitely something that researchers are looking at. If that works, how can we duplicate? How can we replicate this for others? So they're still working on it. But again, if your viral load is down and your CD4 cell count is up, then your body can continue to fight the infection along with the medication. So it's important to know where we are with that. ARC, a condition is called age-related complex, where a person is technically not in the AIDS condition. Their CD4 is not dropped below 200, but they have started to show signs of AIDS-related infections, and that can happen. And so someone came up with the term AIDS, ARC, or age-related complex. The term HIV positive is where HIV has been detected into the system. Early on, when this condition was first identified back in the early 80s, late 70s, early 80s, it was related to it was called gay-related immunodeficiency, because they were seeing these in the gay male population, and trying to figure out, the only connection then at that point was that the individuals that were getting infected happened to be from the gay community, and so a term was phrased, gay-related immunodeficiency. But we found out later on it's not a gay disease. It's not a disease of a hemophilia. It's a disease of humans, and it affects all humans, or anybody that can contract this. It can affect them and infect them. And so the term, I think, has been dropped over the years, but for history's purpose, that was one term that was used many years back. Another term is HIV negative, whereas that means HIV has not been detected in the body. It doesn't mean that you're immune to HIV. It doesn't mean that you'll never contract HIV. It just means that the test at the time, and we'll talk about testing later on, and it has not been found in your body at the time. And if you have a good testing process, and you also have a good process where you're doing education and letting the individual know that what the parameters of the test is, whether it means that your test is good for 30 days back, 90 days back, 6 months back, or if it's good from however far back. There are some limitations to the test. Some of the tests that are out that we have available now can test as little as 18 days, some as little as 10 days of infection. What we like to do is to be on the safe side is a person test HIV negative with the understanding of how they think they might be been exposed, whether they have not, is to find out if what their exposure was and what type of exposure. In the pre and post test counseling that we do, we find out that what those indicators are, and when we find those out, we let the individual know that this test is good. We'd like to retest you back in 30 days or 60 days or 90 days. Early on, when we first started doing HIV testing, not just the rapid test, but HIV testing, a person will be tested be tested in 3 months, 6 months, and a year to make sure that they were not HIV positive. And I believe some of the post-exposure prophylaxis with, if, for example, an accidental needle stick, a nurse or someone was giving an injection to someone and then got accidentally stuck with that, they would test the patient and to make sure that they were not HIV positive, and then that nurse or healthcare individual will be tested in 3 months, 6 months, and a year to confirm that they didn't have HIV. Whether that patient had HIV or not, they'd also be tested for other things. But that was the protocol. Now, a person that has HIV, that's HIV negative, but they have some concerns, we'll test them, 30 days, 60 days, and 90 days, and if they haven't contracted it within 90 days, and there's been no other exposure, that's the key there, no other exposure, then we would consider that person HIV negative, and we wouldn't follow up with that individual unless they had another exposure. A lot of things happens that for healthcare workers, for them to be more effective and more efficient, is the dialogue that we have with the individual that's being tested. That makes all the difference in the world. So it's important not just to know that I'm HIV negative, but why am I HIV negative, and how can I stay HIV negative, and how can I prevent myself from the exposures in the future, and if I have what we consider a high risk, I engage in high risk activities. Of course, we have to identify what those are. We need to know what those can be, and then how we can prevent those. Again, that's a whole other conversation that we're going to have later on, but I just thought I'd throw that in there. STDs. It was also called VD back in the 70s and 60s. VD was venereal disease. Most of the time, those were chlamydia, gonorrhea, syphilis, and things of that nature. And a lot of times you can get some medications and clear it up, relatively quickly. But then the terms came to STD, sexually transmitted diseases. People didn't like that phrase, saying I've got a disease. And someone said, let's call it sexually transmitted infections. And of course, that's my take on all this. And they would prefer it to be an infection rather than a disease, especially since some of those can be cleared up and can be cured. Others cannot be. All right, a few more terms. MS. Yes, all right, I'm ready. Let me see. Do I need to get the chat box?
I think it's okay. It related to the viral load that cannot be connected when referring to the gentleman who had the bone marrow transplant. So what does it mean when the viral load cannot be detected?
So that one more time now?
Yeah. Does that mean that his viral load cannot be detected when referring to the gentleman who had a bone marrow transplant?
What happened, what I remember reading is that when the bone marrow was transplanted, I would assume that there was some sort of cancer, and I don't remember the whole thing, but for some reason they had to kill the old red blood cells, where red and white blood cells, and when they did the bone marrow transplant, of course, that's where our new white blood cells and red blood cells are created. With this new bone marrow, of course, our red blood cells replicate or die within about 90 days. The white blood cells, I'm not sure what the lifespan is, but I would assume it's around the same. And so when those die, these new the bone marrow that's put in there replaced that old blood with new blood from this new bone marrow. So what happens, the new bone marrow with the new resistant, it came from a person who does not have the receptors on the white blood cells to be able to allow HIV to get inside. And I'm going to show a picture of that in a few minutes, how that works. If you don't have the receptors on your white blood cell, then HIV cannot get into the white blood cell to reproduce. So therefore, after a time, it's going to die. So what happened is the viral load would soon begin to deplete because it's not replicating. So yes, it's dying off because it has nowhere to go. So with this new bone marrow, what happened is that the new bone marrow doesn't have the receptors for the white blood cells to come in, and so HIV does not have any place to go. So naturally, it's going to die. So the viral load is going to go down. So yes, does that answer the question?
I believe it may. Yes, it does. Ms. Young indicated it does. Thank you so much.
Fantastic. And if I get too technical, please stop me, because I get wrapped up in my brain sometimes, and I have to wake myself up sometimes, just to make sure I'm not over talking somebody, and I don't want to be disrespectful to anybody here. I want to make sure I'm being helpful in all sorts of ways. All right, so thank you. Thank you for that question. That's a very good question, and that will help out when we get to this. Hopefully, when I get to another screen or two, it'll maybe make a little bit more sense, in case it doesn't. MSM, men who have sex with men, that's a term that used to say homosexual versus heterosexual. We used to say gay and lesbian rather than in some of the terms that are still out there. But we wanted a term that was more appropriate at the behavior and the activity rather than just the group that may be associated with it. And so the MSM, men who have sex with men, was phrased or coined. The phrase was coined, and the reason we did that was because there's some men who do have sex with other men that do not consider themselves homosexual. They don't consider themselves gay. They don't consider themselves bisexual, and so it didn't fit into any of the categories. And so the term came up is, okay, so I'm a man who has sex with other men, even though I don't feel like I'm gay or bisexual or whatever. For example, men who may have been in jail or prison and engaged in sexual activity while they were there with other men, and come back out and maybe they don't do that anymore. Okay, that's fine. But they didn't consider themselves gay. Well, they were still a man who had sex with another man. And so the term was phrased. And it's also a category that we use for risk factors when we're talking about how people can contract HIV because of the behaviors that are typically associated with the groups. IDU, injecting drug users. It used to be called IUD, or intravenous drug use, IVD, because there's some drugs that are out there that are not injected into the veins. So we had to change. It had to be changed. Professionals changed that to injecting drug users. So, for example, you have someone that is on a football team and they're using illegal drugs or whatever to enhance their performance, steroid use or whatever, and they would go down and use the same needle on multiple players. I know that sounds frightening or disgusting, but it has happened in the past. And so even though they're not using it in the veins, they would use it into the subcutaneous material or into the muscle. That's an injecting drug. So what happens if we borrow grandma's diabetic needle maybe she has diabetes and I have diabetes and I can't afford to get diabetic needles, and I love grandma and I trust grandma. I don't think grandma's done anything or grandpa's done anything that can do it, but I need to get my insulin. So I borrow their needle, I don't clean it out. And because their insulin, my insulin, it's all the same. I'm using the same one. And so I inject myself with my insulin. Oh, but I didn't clean it out. Well, guess what? We didn't know grandma or grandpa had an encounter or activities and with someone else. I don't know if they shared needles with someone else or maybe they had sexual activity or something, but they had HIV and we didn't know it because they failed to tell us about that. Again, that's injecting drug use. That's the sharing of needles that haven't been cleaned. So injecting drug users, that's possible. That's the ones where also when you're saying somebody's using illegal drugs, heroin, injecting cocaine or other injectable drugs for whatever recreational drug use, and we don't clean between them. You also have problems with people who have hepatitis C. They pass that on. Hepatitis B, they can pass it on through the sharing of the needles. And of course, the same thing with HIV. What's the first thing you do if you know anything about drugs and alcohol? What's this group that we're working with? I'm pretty sure that you're very familiar with that as a prevention group. The first thing they do is they inject it. They'll stick the needle in, and if they're trying to hit a vein, they want to pull back just on the plunger just a little bit to make sure that it's in there. The blood gets into the vial, guess what? And it's mixed in there, and then you pass it on to the next person, so they get a direct dose of that person's blood that was using it just before them. Then we have the phrase heterosexual, means sexual activity between different sex partners, and now with gender identity and gender preferences, and then this people can fluctuate between male and female, and I don't feel like I'm either today, which is what we're going with in healthcare professionals with gender identity. This can be a little confusing, and we're still working on getting those terms. But at this point, it's the sexual activity between a male and a female. Homosexual, sexual activity between same-sex partners. You have the term women of childbearing age, from menarche to menopause. You have adolescents from ages 13 to 19. You have bisexual as a term, sexual activity between both same-sex and different sex partners. And as soon as my mouse will remove. Okay. Other related terminology that I was educated on quite a few years back from some of my colleagues is download. Men who have either have had sex with another man or but does not consider themselves gay or bisexual. They also may have a family. They may have a different sex partner, a female as a partner or a wife or whatever, but continues to have what they call down low sex with other men. And that was a term that was phrased a while back, and so my colleagues talked to me about that and how that works. And this was where we're finding that the men would have sex with other men and bring back infections or diseases to their family members, and their family members were not aware that they were having sex outside of their marriage or outside of the relationship, and then the partner will be get infected and find that way, and then of course then all the information about what was going on. So that was another terminology that came up. Another one is transsexual, a person who self-identifies as a member of the opposite gender, opposite of the one that's assigned them at birth, usually involves changing the sex of the person through hormonal and surgical procedures. Then you have transvestite, a person who occasionally dresses the one as the opposite sex, plays the role of the opposite gender. And then you have those that are called have transgender. Other relating to designate a person who has identity does not conform unambiguously to conventional notions of male or female gender, but combines or moves between these in some cases. People who are assigned at gender, usually at birth and based on their genitals, but who feel that there's a false or incomplete description of themselves, non-identification or with or non-presentation as the gender the person was assigned to at birth. That's saying we have all kind of things that have been added to that. You have queer, you have individuals that decide that they don't feel like they're gender specific, and that's okay. with any of these. It's just understanding each one of these is a constant learning process for anyone. So it's important to know that these terms are added daily. They can change at a moment's notice, but just to be aware that we need to be respectful of those individuals, regardless of how they present themselves, what they consider, how they call themselves. And it's important to know that we can treat anybody regardless of what their label is. And so it's important to know that these terms may come up, and make sure you familiarize yourself with these. This is going to be very helpful with being able to meet that person where they are and what they have need of. Okay? So I'd like to bring those up and to make sure that we are aware of what these terms may be. And if you're not sure, just ask. If you're not sure what the term is, you're not sure how the person self-identifies, it's always good, and it's always a good thing to ask. I'd rather somebody be mad at me because I asked than for me to assume something. If we're trying to meet people where they are, that's what we need to do, is find out where they are and find out how we can meet their needs. And that's very important. People want to know if you're going to help them. We have a lot of my patients, and I call them my patients because I've worked with HIV and AIDS so many years that I feel a kinship to many of the patients that I work with. And they already have been rejected by so many others. They've been persecuted because of their preferences, their lifestyle, or whatever that may be. And as healthcare professionals, we have to set those feelings and thoughts aside and embrace those individuals and let them know that regardless of what your background is, we're here to help you get a better state of health. And I've had many of the individuals that I work with that we may or may not see eye to eye on things, but we have one common goal. How can we meet the need? How can we get you to a better state of health? And I've had a lot of positive relationships come from that. A lot of people. So again, laying aside our biases and things of that nature. I know that's not part of this presentation, but I think it's very important to know that if we do that, that we'll be more effective in our communities and our neighborhoods because we're meeting the person, we're treating the person, we're not treating the condition, we're not treating the disease process. Again, we talked a little bit about injecting drug use. We talked about mother to child in a birthing process. This is the ways that HIV can be transmitted. Blood transfusion, and of course, unprotected sex. Again, that's the definition of that is where we're having sexual activity without some type of barrier device. And barrier devices includes male condoms, female condoms, dental dams, any type of physical barrier between the two individuals and the bodily fluids that they have. And we talked about the injecting drug use and how that's passed on mother to child through the birthing process and through breastfeeding. We have a wonderful process and system here in the United States that a person that doesn't have access to supplements and stuff like that, they can get those through the social services, through other types of processes that we don't need to encourage breastfeeding if a woman is HIV positive, because they can contract, the baby can contract HIV through the birthing process, but also through the breastfeeding process, the whole process of the milk itself, and also the blood that can be consumed when the actual breastfeeding process is taking place. So we don't encourage that. And maybe in a third world country where someone has the risk of starving to death or contracting HIV and maybe treating HIV, you kind of have to make a little bit different decisions there. But we know in this country that we can we can prevent that, because a child can have a HIV positive mother and or an HIV positive father, but the child does not have to have HIV. The child can be born without HIV. Particularly if we find out early in the process that we can give medications to the mother and the child, it greatly reduces the chance of that child being born with HIV. And that's definitely something that we really want to do, is decrease the possibility of a child being born with HIV. And if nothing else, that's a really good selling point for the mother and the father to go ahead and get tested, because if we know, then we can go ahead and get treatment started for the parents and for the child. And blood transfusions, while it's very rare that it's going to happen, because blood has been tested since the early 90s, and even before that, we've tested blood for HIV. That still could possibly happen. Again, if there's a time between the time of infection, the time of testing, maybe they're in that incubation period that it hasn't actually shown up on the test yet, or the antibodies haven't shown up, or the antigen hadn't showed up on the test, there's a slight chance, but it's very rare, that a person's going to get HIV through a blood transfusion. There are things where you can get blood products, and you have to get them from multiple donors, and that increases the chance, but it's very rare. And if you're worried about that, you can always bank your own blood if you know you're having an upcoming surgery, and you can use your own blood. All right. Other ways that HIV can be transmitted, and the top three are sweat, tears, and saliva. So if you were going to take that test, that's at the end of this. These are you'll need to know these three. That three things that the ways that HIV cannot be transmitted. Is sweat, tears, and saliva. If sweat could transmit it, then it would be every contact sport would have to be outlawed, or we're going to have everybody's have to have rubber suits to wear. Mosquitoes are not going to transmit it. Casual contact, hugging and shaking hands are not going to pass it on. Eating food prepared by someone who's HIV infected is not going to pass this on. Using toilets, showers, chairs, water fountains, etc., not going to pass it on. Being in the same room as someone with HIV, not going to pass it on. Those are not things. You have to actually engage in the exchanging of bodily fluids, with the exception of sweat, tears, and saliva. Bodily fluids that can pass these on. These three are not those that's going to pass it on. And just so you'll know, again, we have HIV or AIDS cannot be spread by sharing of food, bed linens, doorknobs, telephones, towels, combs, swimming pools, etc., kissing, hugging, toilet seats, things like that. That's not going to pass it on. Might pick up something else on toilet seats you might not want, but not HIV. That's not going to be passed on by those. Now, we got to the point where it's probably a time for a quick pause just to see if there are any more questions. We're have about 45, not quite 40 minutes left in the presentation for today, and I don't want to overload you, but I definitely want to give you time to take a breath. Anybody has any questions at this point?
We don't see any new questions right now. As a reminder, under the handouts section of your GoToWebinar block or box, the material from today and tomorrow is downloadable. So this material will also be posted online, as well as a recording of the webinar in the next week or so too. But in the meantime, Al, do you want to take just a small break in the meantime?
Sure. Sure. Let's take a 5-minute break, and or actually let's take a 2-minute break. Whatever you want to do.
Okay.
Just take a break.
Yeah, let's take about 3 or 4 minutes, and we will gather back together about 9:54. That will give us 4 minutes.
Okay. 9:54.
Okay, Al, if you want to jump back in whenever you're ready, we'll be ready on this end.
So are we ready?
Sounds good.
All right, let's do it. All right. So we talked about how HIV gets into the white blood cell, which also corresponds to how medications stop HIV from replicating or making little babies. So we need to understand a few things about, as I back up a half a step just a second. Anybody ever heard of MRSA? Oh, I see lots and lots of hands going up. No, not really. I was just picking. But the methicillin-resistant Staphylococcus aureus is a condition that's a staph germ that's become resistant to medications. And what's happening over the years is we've done this to ourselves. Oh, I know. I get that deer in the headlight look. What do you mean? I've done that. It wasn't me. I didn't do it. How many of you out there have taken an antibiotic that the doctor prescribed, and when you started feeling better, you stopped taking it before the series was out? Or how many of you have taken medication, and when you started feeling better, maybe it's a heart medication, maybe it's a diabetes medication, and when you started feeling better, you stopped taking it? Or some other medication. What happens, these medications in many times don't actually kill viruses, bacteria, or diseases. It stops them from reproducing. So for those of you that did not know that, if they have a doctor tells you to take a medication for 7 days, or take it for 14 days, or takes it for 21 days, what those typically are is telling you that that's the life cycle of that bacteria, virus, disease, or pathogen that you're trying to fight off. And if we don't take it for the entire time the way it's supposed to, then those bacteria, viruses, or infections, or whatever we want to term or term them, will come back again. And what they do is they learn how to be stronger each time that you stop taking the medicine and you start taking the medicine again. Yes, it helps them become resistant. So what's happening there is that we are contributing to the downfall of the medications and them not working as good. Or overusing medications is another part of it, where we're using medications for sinus infections or allergies or colds, and a lot of times those don't necessarily do anything, but it makes us feel good because the doctor gave us something. So this is what happens with HIV. The medications that we have here helps the human body prevent HIV from replicating. And it does it in quite a few places. So we have entry fusion inhibitors, reverse transcriptase inhibitors, and there's two under there. There's an NRTI and there's an NNRTI. There's an integrase inhibitor and protease inhibitor. And many of you might say, Al, wait a minute, you're getting too deep with this. I understand. I'm just trying to give you the HIV 101. Some of this is HIV 201, and some of this is HIV a whole lot deeper than that. But this is going to make a little more sense, maybe, hopefully, as we go up. But if we can stop HIV from replicating in all these different areas, 1, 2, 3, 4, 5, 6 different areas, we have a greater chance of the virus dying and not replicating. So that's what we want to do. We want to use medications that affect these in multiple places and not just one. So we have all these. Now, you're also probably going to say, Al, I won't remember these after these presentation. I don't know. What I want you to remember, if you don't remember anything else, is that there's the medications work in multiple places to stop HIV from replicating. Therefore, if HIV cannot replicate, it dies. It has a fairly short lifespan, but it needs to replicate in order for it to survive. Okay? And if any questions come up, please let me know, and we'll go on. Now, here's where the picture I was telling you about a little bit earlier, when the question was asked about the bone marrow transplant and the receptors I was telling you about, And if you look here under number 2, on the right-hand side, upper right-hand side of your screen, it says entry. Virus binds to a CD4 molecule and one type of core receptor, either a CCR5 or CXCR4 receptor molecules are common on the cell surface. Then the virus fuses with the cell. So if we don't have these CCR5 receptors or CXCR4 receptors, if we don't have those, then HIV cannot bind to the white blood cell. It can't connect to it. And if it can't connect to it, then it can't get inside to replicate. So when we have a person that may not have these receptors on their white blood cells, which does happen, it doesn't mean they're immune to HIV, but it means that they're less likely for HIV to replicate inside their body, which means that they have a good resistance against HIV. Let's put it that way. I don't want to rule out any possibilities, because just as sure as I say, oh, they're never going to get it, that's the one that gets it, and then I get in trouble for saying it. But what I can say is that if they don't have these receptors, it makes it extremely difficult for HIV to replicate inside their body. And just like anything else, they all have a life cycle. Remember, our white blood cells, our red blood cells have a life cycle of about 90 days. Anybody ever heard of an HbA1c test for diabetes? That's where a person who might be cheating and been eating cakes and cookies and pies and stuff like that all the whole time, and then 3 days before they stop eating all that stuff, so when they have their finger stick test, it shows that they've got a low blood sugar count. Well, if a person gets an HbA1c, it'll tell them how they've been doing for the whole 3 months, not just for the past 3 days, because it looks at the life cycle. Because what happens is these the red blood cell tells a story of what's been happening for the last 90 days before it dies. So that's why when we have an HbA1c, we want to have those every 90 days. I know that's not HIV, but again, this is trying to give you a kind of parallel of how this works, and that we all have a life cycle, and red blood cells is typically 90 days. So the first one is the virus is trying to get to it's inside the body, and this is a picture of a white blood cell or a CD4 molecule or a helper T cell, and HIV, the one that's the darker one with the little burgundy maybe and the aqua colors, and I thought there only used to be the 8 colors in the thing, rainbow, but they've got all kind of aqua colors, and we got a tans, and we got some beige, we got some fuchsia, we have all different colors in here. So what's happening with number 2 is the entry inhibitor. If we have a medicine that stops it from attaching to the cell, then it definitely can't get into the cell. So that's one area. The next one is the penetration there. That would be the fusion inhibitor, where it fuses to it and then it enters. So you have number 2 actually would be the fusion, and then the number 3 would be the entry inhibitor. So we have it keep it from getting inside the cell. So there's 2 things before it even gets inside the cell. 2 medications. If they're working together, they keep HIV from getting inside. If they keep HIV from getting inside, then they can't replicate. Well, maybe they get inside. What's the next thing? Well, number 4 there says reverse transcriptase. There's NRTIs and NNRTIs. So the non-nucleoside reverse transcriptase. What it is anybody that has a biology background will probably pick this up. HIV is an RNA, a ribonucleic acid. However, we have DNA, which is deoxyribonucleic acid. And what happens is in this process, HIV gets inside the cell, and then what it does is it converts from RNA to DNA. And then once it gets from RNA to DNA, if it gets to that, that's where the reverse transcriptase comes in. There's 2 medications, 2 different types of medications that prevents it from converting from RNA to DNA. So if we got 2 more places, so we got 2 on the outside, and now we got 2 on the inside that can then stop it from replicating. So if it can't get it into a DNA format, then we're good. What happens if it gets past that? And then we get into the inside or the nucleus of the white blood cell. It gets inside there, and what it does is it takes its DNA and fuses with our DNA. Now we have a new hybrid that's HIV plus me, HIV plus me, and then it starts to make new babies. And that's when they start, that's another medication right there, prevents these two from fusing. Prevents it from fusing. Let's go back up one to the where it says integrase inhibitors. It prevents them from merging together. So we have the first two from getting in the inside, then the next two keeping it from changing from RNA to DNA, and then the next to last one down that says integrase inhibitor prevents it from actually merging to our own DNA. Again, that's where they start making the babies, is when they start merging these together. And then if we can, the last thing is once it comes back out of that nucleus, now we have new strains of HIV that are HIV plus me. Well, that's my HIV now, and it's an immature virus at that point. If it doesn't get a protective coating around it called a protease, if it doesn't get the protease around it, then it's going to be fragile and more likely to die. So you have, that's the protease inhibitor back on this other page, very last one. And what we in medicine, we used to use individual medicines, and then we started using cocktails of 2 or more, and then we became 3 was the standard. Now we're at 4+ medications wrapped up into 1 or 2 pills, and they're most effective when we have all these medications working together. The downside to this is if a person starts taking a medication, stops taking a medication, starts taking a medication, stops taking a medication, that easily makes that HIV, that virus, become resistant. And when people do that, it makes it difficult for us to be able to, as healthcare providers, give them a good regimen that's going to work for them. And they do become resistant, and there are tests out there that lets us know which one of the medications are going to work best for them. And please note that we are very limited on the medications that we have. We are coming up with new medications, 2 or 3 a year, it seems like, but it's still very few and far between that we get some that are actually being effective when we get resistant strains all the time. So if a person's on medications, they need to stay on medications until their provider tells them otherwise. They need to have regular routine checkups and have blood drawn every 90 days, and at the very least every 6 months, because we don't know what's going on inside the body, and we want to make sure that the medications that we're giving are actually doing a good job. And we don't want a person to become resistant to it, because when they become resistant to it, they've taken the medicines for absolutely no reason. And folks, I don't know if you know anything about these medications, but these are super expensive medications. They can cost anywhere from $2,500 to $4,000 a month for the individual, their medication, whether they're paying for it or whether you and I are paying for it out of our monies that we're paying in for taxes and whatever else. Somebody's paying for it. It's never free. Never, ever free. But anyway, this picture is a really good example of how HIV actually starts and replicates in the different places and medications are going to be effective. All right, so let's move on a little quicker. This is the electron microscope. The little green dots are HIV on a white blood cell, and it's just a colorized version of an electron microscope. It's one of the only pictures that I've been able to come up with to find that somebody actually colorized somewhere. So what HIV was budding in green from a cultured lymphocyte, and you see how it's attacking in large numbers, and at some point it gets so large that there's no way you can keep up with the numbers of HIV. Here's what happens when HIV gets into your system. It's at day 0. The primary infection is the red at the very bottom. It starts off really small, and your CD4 is your blue, or your immune response is blue. So when HIV starts getting inside the body and replicating, the first few weeks you might not notice anything at all. And around the 2nd to the 3rd week, maybe, then you will start having flu-like symptoms. Why? Because your body's finally saying, hey, there's something here that doesn't need to be here, and it's taken time for us to find it. But now that we found it, we got to kill this thing. And so it begins attacking, and you have very, very severe flu-like symptoms after about the 2nd week or so. And what's happening? It's HIV and your CD4 cell, your helper T cells are fighting to the death, literally, for you. And you see that intersection. It says around week 3. It may be a little before, a little after, but around 2 weeks after a person's infected, they're going to have a flu-like, a severe case of the flu, and it can last for a while, maybe a couple weeks. It could be more. And usually that's an indicator when we start talking and doing our dialogue with the patient to find out maybe when they actually got infected. If we can figure out when they were doing what they were doing, and then about 2 weeks after that, that kind of gives an idea of a person and when they could have got infected. It also helps us to help that patient track who might have infected them, so we can go back and hopefully maybe get contact with that patient and let them know that they need to be tested, if we can find that information. And we do it confidentially as well. And of course, you see how whenever HIV goes up, the CD4 cell count or your immune system goes down. Usually after that, after the peak for HIV in red at the top of what looks like 6 weeks there, you also see that the bottoming out of your CD4 cell count. But then all of a sudden you see your CD4 cell count jump back up, and then you see the HIV dropping. And that's what happens because your immune system does a fairly good job at defending it. But because HIV replicates exponentially, it's hard for our body to keep that up. We have a finite amount of CD4 in our body, and there are some medications that help to boost that. A lot of times there's a lot of bad side effects with that, and so we don't use those as much as we used to. But because there is a finite amount of CD4, it's hard for it to keep up because HIV does replicate exponentially. But then you see there's a gap there between week 12 and the years. Then you'll see as HIV begins to build, your CD4 over time begins to drop. And of course, over time, death. Where it says there's 10 years there, for someone who's never been tested, never had any idea that they might have HIV, it may take anywhere from 8 to 10 years before it actually shows up that you have any signs or symptoms of HIV. When it gets below 200, then that's when you start showing signs or symptoms. But, you may pass it off as I just got bad colds and I just, caught the flu a few times and it's just hard to get over. And we need to make sure that we're tested early. Anybody that's ever been exposed to somebody else's blood or bodily fluids, regardless of age or who they are, who we think they are, they probably need to be tested at least once in their lifetime just to make sure. And of course, if you're routinely exposed to people's blood and body fluids, professionally or otherwise, it's just a good idea to make sure that you maintain a routine testing. That way, if you do get or contract HIV, you can have a long, healthy life. A person that has HIV, that it takes care of themselves, takes their medications, doesn't drink or smoke, can live the same number of years as someone who's never had HIV. It's just one of those things that if you don't take care of yourself, it's going to catch up with you, I promise you. How many cases are there out there? This goes up through 2015. I know we're in 2019 now. That's 4 years later. But just to give you an indication from 2000 through 2015, how the numbers have gone from 28.9 million people living with HIV to 36.7 million. This is worldwide. And out of those 36.7 million, less than half are actually getting treatment. That's pretty sad, especially with the medications and the programs that we have now. Why so many people do not have access to medications. All right, let's something to look a little bit closer home for those of you that are not in Robinson County. If you'll go to the North Carolina Department of Health and Human Services website and the Communicable Disease Division, this particular one was from the epidemiologic report, and I found out that they're not making the epidemiologic report after 2012 or 13, but there are lots of facts and figures that are still out there. And they do have information for your area, your site. If you're not from North Carolina, you can always go to your local government's website and type in HIV or communicable diseases in your state. and they can you can get local information. Used to this was only available at your local health department, but now it's readily available online. You can get these every day of the week. These are something I pulled because I'm in the Robeson County area, but we do treat others. But look at this: chlamydia and gonorrhea rates versus North Carolina per 100,000. Chlamydia, the dark blue on the very left at 2012 was much higher than it was in 2013. But at the same time, if you look at the North Carolina rates were much lower. So our county has a lot more levels of chlamydia and gonorrhea than the state in itself. And these are the rates, of course. These are not the actual numbers, but we have to understand that per capita, per 100,000 people, that's pretty significant. And if you can get chlamydia and you can get gonorrhea, which they're easily preventable by using the use of a condom or dental dams, you're greatly reduce your risk of getting HIV because the bodily fluids that are shared for contracting chlamydia and gonorrhea, you can also get HIV through these. HIV disease by county rank and order. This is, again, 2012, 2014. Some will say, hey, what happened to the new ones? I got some more newer numbers, don't worry. But Robeson was ranked number 15 with an average rate of 16.8 in 2012. And again, North Carolina ranked between 19 and 21. So again, we're higher rating, number one being the worst in this particular case. So Robeson County has got a lot of cases of HIV compared to North Carolina, and that hasn't changed a whole lot in the last few years. HIV disease is living as 2012. We had 424, and back in 2009 we had 389. AIDS living cases by 2013 was 215. And at the year before was only 210. Didn't get but 5 new ones. We're having hopefully fewer and fewer people that are living with AIDS and more that are living just with HIV. That means you're not getting the AIDS condition. And hopefully, what our goal is that if somebody is HIV positive, that they're not converting to AIDS as quickly, or they're not developing AIDS as quickly. Because we're getting them into care, we're testing and we're treating, and that's what we want to do. And identification, for you professionals that are out there, you can help that. You can encourage people to get tested. You might see those individuals, you might talk to those individuals, and you can say, well, hey, if you're engaging in these behaviors, this might be something you want to consider having done, because it's not a death sentence anymore. HIV is not a death sentence. It does not have to be a death sentence. Let me put it that way. It does not have to be a death sentence. If a person gets tested in a timely fashion, they can get into treatment and get into care. And there are programs all over the state, all over the nation, in all the 50 states and some of the territories, in Puerto Rico as well, as part of our of the United States territories. There's lots of programs for HIV care. So even if just because you're HIV positive makes you automatically qualify for any discounts that may apply, but again, if you don't know about them, we can't help you get into those programs, and we will help you get into those programs if you will let us know. Robeson Healthcare is one of many programs that are out there, and that I work for, but there's other programs across the state and across the nation, and each, if you contact them, we can actually help you to get where a program is in your area, and help you to help somebody else find treatment and care programs in their area. Chemo diseases from 85 to 2011 is over 615 in this small county of 130,000 people or so. Doesn't sound like much, but when you're trying to get them all into care, it's tough. When again, there was 260 estimated to be in care back at that point. 130 plus or minus were not in care, because we have a program at Robeson Healthcare. The health department has a program. You have Shrayheck and Fayetteville has a program. You have Commonwealth Health that has a program up in Newton Grove area. Plus, they have other satellite sites as well. And there's others. There's some in the Charlotte area, and they have programs. And it's just sad to know that there's people out there that are not into care, when we have people that could be helped if they would just see if we could help get them into care. All right, looks like we got about 10 more minutes. I don't know how much further I want to go, Jamie. If we have questions, I'll run right up to the edge there. I'll make sure I get enough. If you want to pause and ask any questions.
Sure. Anyone have questions out there? Al, there's no questions at this point.
All right, so let's just roll on, and we'll run right up to the 10:30 mark, and then we'll pick up tomorrow where we stopped. All right, and thank y'all for hanging in there with me. I appreciate it. For those that hasn't fallen asleep or have their eyes glazed over by now, I'm excited about the new things that are happening with HIV and AIDS. And again, this is something that's dear to my heart, so that's why I love talking about it. And I hope you can be an advocate as well to help us to get people in a better state of health. And I know you can, and I know you will. So North Carolina, this is something that comes directly from the Department of Health and Human Services Communicable Disease. This came off of one of their fact sheets. Yes, I borrowed this, and yes, I use this, and I don't know if I'm in trouble for that, but I want to know that this information you can find on the website. So this is not something that I'm making up. This is real stuff that's happening here. The prevalence rates for North Carolina, newly diagnosed HIV infection rates, and HIV death rates. Well, that's a toughie. Look at the number of death rates. Look how much that's going down over the years. That is fantastic and phenomenal. Again, one death is one death too many. But we must have in some sort of impact. At that black line, you see that's going down to only 2 in 2016, 2017. That is awesome to know. New diagnoses. Unfortunately, it looks like it's dropping off, the number of diagnoses. And I don't know if that's because we're not testing as much or less and less people are getting infected. I'm hoping it's the latter. But if we're not testing, we're definitely not finding. And look at this, the information below there. It says over 35,000 people were diagnosed with HIV and living in North Carolina as of December 2017. Now, this is the most up-to-date statistic. I told you I had some new ones. This is the most up-to-date that we have. It's estimated that 40,000 people are living with HIV in North Carolina, including an estimated 5,000 people who have HIV but are undiagnosed. People are out there. We need to find out who they are so we can get them into care. This is not to persecute, prosecute, or anything else. This is to get people to a better state of health. The more people we get to a better state of health, the more our communities are healthy. That's a whole other thing is community HIV. Community HIV. You know, how healthy are our communities? Well, if we have somebody out there that's HIV positive, don't know they're HIV positive, and they're engaging in activities in our communities, then they're at risk for getting and transmitting that to someone else. We want to reduce that as much as possible. Again, look, it says 1,300 adults, adolescents were newly diagnosed with HIV in 2017. That's phenomenal. I mean, that's a lot of people newly diagnosed. 15.2 cases per 100,000, which is a slight increase from the 1,399 from 2016. Decrease, which is great. I mean, we know that they're less, but if we're not testing, we can't find those individuals. All right, so chlamydia and gonorrhea rates. What I want to show in these next few slides before we finish up is that chlamydia, gonorrhea, and syphilis, in most cases, Robinson, just showing you an example, that Robinson is higher, than the rates for North Carolina. That means our risk is higher. The people our communities are not as healthy. We want to do something to make an impact on those. Here's 2015. The numbers are still incredibly significant to let you know. Robinson is still higher. Here's 2016. Continues to be higher. We need to do something. We need to make an improvement. I don't know what it is for your communities, but if you want to give me a call or contact me, and after tomorrow, send me an email. I'm not the HIV Services Director anymore. Carla Mons at Robinson Healthcare is, but I'm really available to help you to find this information if I can. I work with Carla regularly, and she tries to keep me in line. And that's a little plug-in for her because she is good at what she does. And we're trying to make an impact in our communities, we as a team. Robinson Healthcare being one, the state of North Carolina being another, and all the partners that come into line with this. Look at this, 2017, it still continues to rise. Incredible. Our syphilis rate is dropping a little bit. That's good. But again, it's still significant. You're looking at chlamydia, gonorrhea, and syphilis and some other formats. That's kind of confusing, the chart, but you have it. You can look at it at your leisure. Be happy to explain those to you if you have any questions. Look at this one, the syphilis cases. We found that back in 2000-ish, that Robinson County had one of the highest rates of syphilis in the nation. In the nation, folks. And as a result, there was a grant that was awarded to Robinson County to be able to, it's called the Syphilis Elimination Project. When you have syphilis, usually HIV trend follows whatever your syphilis trend is. People don't have to die from syphilis, but many times they do. They get infected, reinfected. It's one of those diseases that are in your body. It's doing damage. You don't even know you have the condition, and it's doing extreme damage to your body over the years. And then when it resurfaces years later, the damage that is done cannot be undone, and it could also cause brain damage. It can cause problems with most of your internal organs and cause blindness. And by that time, you don't even realize what's happening, and then the effects cannot be reversed. That's a sad, sad thing, folks. That we could be doing something about this if we could. If people would just we help people get tested and get treated. But you notice there was a spike from around 2010, 2000. The project stopped around 2013, I believe, and then you notice at 2014 it began to spike again. The project lost its funding, and you see it spiked again. Now we're up to the 26 people that were identified with syphilis in Robinson County. Significant stuff, folks. Significant stuff. HIV disease by county rank and order. Again, this is HIV, and we want to make sure that we understand that these are the rates versus the cases, and we're in most cases we're higher for HIV disease than some of your other counties. We're not the highest, but we are among the top 10. In many cases, top 15, top 13. It's still a lot. It's significant out of 100 counties. That's saying quite a bit. We need to work on this. And there's other counties. And again, if you go to your website for North Carolina communicable disease, they can get more specific to your county and your area. I'd be more than happy to direct you if I can. How's the risk of exposures? Who's getting infected more than anyone else? At this point, this is through 2017. This is one of the newer charts that I have. You see that men who have sex with men are getting infected the most, but there's a downwards trend from 2016 to 2017. It looks like it's decreasing a little bit, but the one that's coming back up is the others and unknown. People are just not reporting, but they're still positive. They're not telling you how they got infected, but we know that they got infected in some way, shape, or form. MSM and IUD combined, and then IDU, not IUD, IDU, they're both staying relatively low, but the heterosexual it's decreasing a little bit, but it's staying right there with the other and the unknown. So what does this mean? It means our messages have to be able to target the individuals that's going to be receptive to it. So if we don't have our messages right to the individuals, we don't have the right people in place that's going to be receptive, because if we don't have people in place that people are going to listen to it, the message is worthless. And so that for those of you that are in prevention, you know that the message is important, but also the delivery of the message and how it's received is important as well. Robinson disease by certain percentage by race and ethnicity, who are getting infected most. Hands down, folks, African American, Black Americans are getting infected more and more, and that's not just in North Carolina, that's not just in Robinson County, that's pretty much across the United States. We're finding that to be significant, and that means our targeted for our training and our education has to be make sure it reaches the population that's going to be infected most. We also see there's a spike in our American Indian, and why is that? Robeson County. Well, of course, we know we have the Lumbee population, and they make up a good portion of our population here. Therefore, in the state of North Carolina, it's not quite as high for American Indian, Alaskan natives, but because we have such a high concentration, our numbers are much higher. And at that point, I think we'll call it to a pause and give Jamie the opportunity to make some closing remarks or statements, and then we'll catch up tomorrow and start back here.
Thank you, Al. Again, any questions or items to discuss today? We do want to thank everyone for logging in. We have 108 people who logged in today, so that's really good. So tomorrow we will start at 9 a.m. and finish up by 10:30 again, using the same link that was used to enter into the GoToWebinar classroom today. Again, tomorrow we'll take care of some of the housekeeping items in terms of the training survey and final Q&A type of issues. In the meantime, if you have questions or concerns, just let us know, and we will see everybody virtually at least Tuesday at 9 a.m. Thank you.
Jamie, you still there?
Yeah, I'm still here.
Oh, okay. I didn't know if you want to do any follow-up or anything. Is there anything that you wanted to go over?
Yeah. I think let me give you a call back on the private line while I shut this while I shut the GoToWebinar instance down. Thanks.
Are you going to call me 876-2249?
I believe so. That's the number on your signature, right?
Yes, that's my cell number. Yes.
Okay. I'll give you a call right now. Thank you.
Sounds good. Thanks.